Hi, good afternoon, everyone. I'm Karen Landon. I'm the Director of Solutions Marketing with Nuance, and we're pleased to invite you to our webinar today. We understand the challenges you face each day improving the quality of care you offer your patients and your community, and doing so with efficiency while managing costs. We're pleased to share with you an approach to engaging your surgeons in a better documentation experience for improved quality care and communication between care members, resulting in more accurate reimbursement for your organization and for the physicians themselves. Nuance has expanded our artificial intelligence and documentation guidance solutions for physicians through a partnership with Vincari as the leading solution for surgical documentation. We're very excited to share the solution with you today. So I'd like to take a minute to introduce our speakers. Today we have with us Dr. Lucian Newman III, practicing general surgeon in Gadsden, Alabama, specializing in minimally invasive surgery. Dr. Newman practices with his father and brother, who are also surgeons, and his family has practiced and served the community for over 100 years in their area. Dr. Newman is passionate about creating a more user-friendly environment for physicians to deliver more accurate and complete documentation. He's currently the chairman of the Blue Cross Blue Shield of Alabama and the founder and Chief Medical Officer at Vincari. Dr. Mercedes Dellum brings over 30 years of clinical practice as a cardiothoracic surgeon with numerous leadership roles in both hospital settings, private practice, and integrated medical practices. As the regional medical director at Nuance, Dr. Dellum serves to help our clients engage and involve their medical staff in clinical documentation improvement initiatives. We also have with us today Ryan Dorminey, who is Vincari's Director of Product Management, who will be sharing with us a demonstration of the product and who's brought the product with us to bear today. Let's take a quick look at our agenda. We'll cover a number of important thought leadership discussions around the value of clinical documentation and the importance of what we write in our surgical documentation. We'll take a look through and see it in action, so you can understand how the workflow works in the care settings. We'll discuss a few final thoughts, and you'll be invited to ask questions at the end once you've had a chance to take a look through the presentation. So just a few thoughts to kick off the presentation today. When we're looking at using artificial intelligence to address common problems, there are a number of issues that we all face and that we're looking at addressing as healthcare systems around provider burnout, addressing healthcare costs and quality, and so forth in terms of how clinical documentation and artificial intelligence can help impact those issues. Realizing that artificial intelligence brings efficiency and scale to complement your efforts to address issues where quality of clinical documentation is a factor. And also to think, as part of your clinical documentation improvement strategy, consider the unique needs and workflows of the surgeons that work in your organization, how you can enable them with intelligent solutions that meet the needs of those surgeons instead of asking them to change their workflow. So what I'd like to do today is introduce Dr. Newman and turn it over to him to start the content of our webinar.
So thank you very much, Karen, and thanks for joining us today. And as Karen mentioned, accurate surgical documentation is critically important today, probably more so than ever. If we look at the status quo of what's happened in the past is a surgeon finishing their work simply dictated or used voice to text into a transcribed system where their thoughts went on paper. The reality is that we are being measured very carefully by third-party payers, by the health information professionals, and so getting it right the first time is very, very important. The history of this is that we never have had access to a rules engine as we work, and in order to make sure that we're capturing the right information, a rules engine is very important. Additionally, the topic here is how AI or artificial intelligence can engage surgeon behavior. And, it's kind of interesting that we live in a world today where AI exists around us and we don't even know it. You can think about Siri or Alexa, Google Maps or Nest or Waze or Pandora. All of these are systems that actually help the user shape their responses. And so responses that are given by the user creates a different input. And so true AI actually learns on its own. And so this is actually probably best summarized as machine learning. The original or beta name of this product was actually Raptor coding. The reason was velociraptors are fast, and they tended to remember in Jurassic Park where the fences were down. And so, you know, it is interesting that many of our software tools that we've used in the past and today, they don't have that behavior, but this one does, and we'd like to show you that to you today. Next. So when you really look at CPT coding, every surgeon, every medical doctor, every person that's billing actually has to create a work product. And so the CPT system is what was designed to capture that. And that actually determines the payment for the services rendered. And so what you see before you is actually the factor that is used to calculate the work RVU, which does not change in different areas of the country, as opposed to the other components that do. And so your malpractice expense and your cost of maintaining practice and your geographic adjustments, that's how people in New York get paid differently than Ames, Iowa. And so the conversion factor is something that is used by CMS yearly to determine how much each unit is worth. And so in that manner, they can control costs and control payment to different providers that are billing the system. Next. So the end of the list of CPT variations is literally endless. And so most surgeons who are expert in their subject, believe it or not, most of these people haven't actually spent the time to look in exactly what is pertinent to their particular operations. And so, for example, thyroidectomy, which I perform, there's actually 11 different CPT codes, which changes the WRVU, by over 100%. And so the nuances in the language that we use to describe an operation may or may not trigger your coding professionals to use that code. And so by using rules engines, we're able to make sure that the surgeon is capturing exactly what they meant to capture. So if you look at other surgeries, and once again, this is endless, but pericardial, prostatectomy, hysterectomy, common interventions where minor language changes can actually change the CPT code and therefore the work RVU and reimbursement. Next. So when you look at just hernia variations, I'm a general surgeon, been in practice for 25 years, and historically, if I would have dictated my note immediately after a procedure, I still may forget to remember or to describe an incarcerated hernia or a recurrent hernia. And so very often surgeons in their busy days, they may wait and dictate things later in the day or even that night, or unfortunately, days or weeks later. And so the encouragement of creating these notes very quickly requires help, and the help in this manner can come with a rules engine and using a tool such as Vincari to do this. Next. So when you look at complicated procedures or complex procedures, we know that regardless of the body system you're operating on, there's almost a hierarchy of walking up to the most complicated procedure that's done for complicated conditions. And in the example of nephrectomy here, you can see how the RVU totals change by from 21 to 30 just based on a more extensive code. And so if the surgeon is not familiar with these minor changes or minor language changes, it is entirely possible that they actually perform the complicated procedure, but the coders behind them actually code the other. And because there's never been a true openness between coding and surgeons, you know, this very often goes under the covers. And so, you know, the reality is that the coding professionals that are working behind surgeons are very, very important to your livelihood and to your hospital's safety and livelihood. Next. So when you look at technology, you know, we rely on technology to make our lives better, whether we're in airplanes or buses or shopping. I mean, all of us, as mentioned earlier, use tools on a daily basis that have technology that improves our experience. And so it should be no different in medicine. Unfortunately, EMRs, which were designed 10, 20, 30 years ago, they become what I call large suitcases where you put your stuff, and you really need something to clean your stuff to put it back in the suitcase. And that's what we view this Vincari tool as doing. And so the choices that you can hit at the point of care are literally walking you through adding the language that's required by the coding professionals to complete this document without a query following it days, weeks, months later. Next. So public scorecards. This is something that's easy to deny, but it's reality. So this report's actually several years old and out of California, but this is an actual report with, I know it's blinded on the left, but the actual report had real surgeons and real hospitals. And the reality is that these surgeons, this PDF that I reviewed had some 60 surgeons or so that were labeled as worse. And if you said, what in the world does that mean? Well, you just have to follow over down the line and see that the expected versus observed mortality rate is somewhat askew, and that creates a risk-adjusted mortality rate that is out of skew. So next. So details do matter, and I think Mercedes is going to share this with us.
Thank you, Lucian, and appreciate everybody joining with us today to discuss this important aspects. And I'd just like to touch on a few points that Dr. Newman made about our documentation. You know, it is the coder's responsibility to code a diagnosis that we document. It is the surgeon's responsibility to make sure that what we document is a codable term for them, because they cannot interpret what we mean. We actually have to write it. So if there's no codable term, that means no code recorded, and as Dr. Newman said, you do not get credit for that particular procedure. The other aspect is that these are very complex procedures and with multiple comorbidities. Again, as surgeons tend not to document all the comorbidities because we're so used to taking care of these other problems of a patient, we miss capturing the severity of illness, risk of mortality in these patients. And this is where this search engine and this product will help capture those, remind us that we have to do this, so we won't under-document the severity of illness of this patient. And here's just an example of whether was it a diagnostic or a therapeutic. Again, if we don't document it appropriately, it may get coded out as diagnostic, and that has a huge influence. As you can see, it will be a lower DRG, and you will get less reimbursement as the surgeon, and also less reimbursement for the hospital. And a lot of surgeons say, well, it's not my problem, it's the hospital's problem, they just want us to document. Well, the fact is that if we don't appropriately and accurately document complexity of the case, severity of illness, and the payment is recouped from the hospital, then by law, legally, they can recoup the payment also to the practitioner. So not only will you lose the technical fee, but the professional fee to the provider will be lost. So that's why it's so critical that we do not abdicate our responsibility as the physician caring for the patient to make sure that all the appropriate documentation is there. Next, please. And here's just an example of a patient with acute appendicitis. Again, as Dr. Newman said, you know, we're in the heat of the moment. We're just documenting something quick. It's what we're used to. We thought it was just regular. But if you don't document specifically the type of peritonitis, was it with or without, was there an abscess, this has huge influence on the weight of the case, on the DRG that gets coded out, on the expected length of stay, and again, as I said, reimbursement not just for the hospital, but also for the physician. And this goes into all aspects of surgery. If you're doing a long case, lysis of adhesions, and again, we don't document the complexity of it, say how extensive it was, what was involved, which all will be captured with Vincari software, then you may not get credit for the reason for this complex case. Next, please. The diagnosis specificity impacts, as we said, the MSDRG assignment. So again, with a gallbladder case, if you're doing a gallbladder, we need to specify the approach, which is, you know, fairly straightforward now. But if we don't document the type of calculus, where it was, specifically what area of the bile duct, with or without, again, it affects your coding, it affects the weight of the case, and it affects the expected length of stay, which will, in the end, affect your profile, which will be publicly reported, as Dr. Newman mentioned before. And, you know, there's so many public reporting websites now, and surgeons are a specific target, that if we don't double check our work, go in, I recommend that everybody just type your name in on these different value websites and see what is being said about you, what's being reported. And all of that is based on the code that goes out, which is based on the documentation that we do. So remember that physicians and people working under them, PAs, nurse practitioners, residents, are the only people that can document a diagnosis that can then be converted into a code. Next, please. So I'll turn it over, but I'll turn it over to Lucian. Go ahead.
So I want to revisit that for one moment and talk about a concept that I speak about in talks, and that's the patient you never see. And so the reality is that surgeons, like any other doctor, have patients that are easier to treat. The complicated patients are harder to treat. And in fact, if you never really disclose the other comorbidities, what happens on these public scorecards is that you fall relative to your peers, so that your peers that are actually doing this correctly, they actually look like better doctors when the converse may be true. And so, you know, I've had numerous discussions with physicians explaining how they don't treat heart failure or they don't treat, you know, diabetes, whereas that's true. We have to make special arrangements for many patients, whether you're on antiplatelet agents, whether you have blood sugar issues. And so it does impact the way that we practice our trade, including surgery, based on their comorbidities. So I like to discuss the patient you never see. So specifically, documentation requirements are used by insurance companies such as Blue Cross Blue Shield. And the reality is that they have predeterminations and they have pre-certifications that occur, and the physician is engaged to document everything in these documents. And so most of the time we may not even know what they are, but if you provide a rules engine where the questions are in your face, you do know the answer. And so the doctor typically knows the answer, they just don't always know the question. And unfortunately, so often the question comes at them one day, 1 week, 1 month later from the coding department who are issuing queries. Next. So inpatient-only procedures, you know, this is another concept that most physicians have heard of, but they're not exactly sure what it means. And so it is very easy to do a procedure in a hospital today and send them home unless you're using a tool such as Vincari that has this warning label. And so I actually had a case, a personal case of mine a few years ago before this label was on our document, where I was doing an embolectomy on a clotted femoral graft, and during that case I changed it to a thromboendarterectomy. Unfortunately, what had happened was it went from an inpatient, from an acceptable outpatient procedure to an inpatient only. And so that's an example of something, if your physician just goes to dictate, that the people in the recovery room and in day surgery may not pick that up. But using a tool such as this with a rules engine that discloses the inpatient only procedure listed below, that would tell everyone downstream that don't send this person home. Next.
Actually, Lucian, can I just weigh in on that for a second on the other side?
Absolutely.
The other aspect of the inpatient only is now that this year they've switched for the orthopedic cases, you know, the hips and the knees. I was just recently visiting a hospital, and they're having a hard time with the denials because they're very elderly patients, severe multiple comorbidities, but because the surgeons aren't documenting all these other comorbidities, they're expected to discharge these people in their 80s with all of the comorbidities home, you know, like as an outpatient. So the flip side of that is that if we don't pick up all of the comorbidities, we'll miss, and you'll get denied payment for something as serious as a hip replacement or knee replacement. And that's the advantage also with the software, is that it will trigger you on that point.
That's a great point. Next. So we talk about, are you preventing the accident, or are you just fixing the car after you broke it? And so we view the rules engine and using a tool such as Vincari with artificial intelligence as the stoplight. We're trying to prevent the accident from occurring. And if you said, what's the accident? The accident is inaccurate or incomplete documentation. And so after you create a document that requires HIM purview, they're looking for the perils and pitfalls and the problems associated with that document, because they have to translate this into a bill that's sent to the third-party payer for compensation. Next. So the other part of this talk and other part about artificial intelligence is being able to create analytics. And so we all realize that we are creating kind of a paper trail or an information trail behind us, but most physicians don't get immediate feedback. And so using a tool where you're committing to procedures and diagnoses creates another very, very important downstream benefit, and that's the ability to analyze what you do. And so the number of things that you can actually analyze, whether it's tools that you use or whether it's lengths of stay or diagnoses or procedures, everything that you're doing on a tool such as this is able to be analyzed, as opposed to the way the status quo documentation that's occurred in the past. Next. So charge capture reports is just another downstream benefit, and you know, we surgeons may not know a tremendous amount about this, but everything that we do creates a code, as I mentioned before. And so using this tool, you're able to see what you have actually captured before you actually send this to the HM department, your billing folks. And so in this example, you can see that the laparoscopic appendix was done, and we documented an acute appendix with peritonitis, and then you can see the comorbidities. And so having this type of information available for your billing department allows them to be much more efficient at their job. We're not eliminating coders. This is not a coding tool for surgeons necessarily. It's an information transfer tool, because as I said before, the surgeons know the answers to the question very often. They just don't know the questions. Next. So case tracking and analytics is another important downstream benefit. And so we all know that as we are getting recertified, we have to provide case lists. In fact, there's been a lot of discussion lately about changing recertification processes, and all of these are asking for a more timely update of the cases you performed. And so using this tool is able to instantly create the actual PDF that the American College of Surgeons requires. The other thing I'd like you to think about is all the other quality reporting that's being required, whether it's NSQIP or the information that's generated for the STS. Those are all very important things. And Mercedes, would you like to comment on this slide also?
Yeah, thank you. Yeah, also from the hospital standpoint, you know, as you're getting your staff privileges recertified with that, continue your privileges, you will be able to produce your cases, be able to look up the outcomes so that you can present this for your reprivileging process, your credentialing. And also, as I said, to use it to double check a lot of these quality sites, a lot of the insurance sites, because you will have the accurate data. And if you've ever looked up your own profile, you'll be surprised at how inaccurate many of them are. So this is a way really of protecting and making sure that you control the data that's being put out there, because it's going out. You just need to make sure it's accurate.
Next slide. So now I think we're going to turn it over to Ryan. Ryan, would you like to show the audience Vincari in action?
Absolutely. Thank you, Dr. Dellum. Thank you, Dr. Newman. I'm going to go ahead and share my screen here and walk through the Vincari application. And as the first demo I'll show is as a general surgeon who has used Vincari on a daily basis, and then we can jump back into it and kind of show some of the details and the different features and aspects of the application. So So walking down, or the application itself, you can see here it's got, on the left-hand side, we have the navigation. On the right-hand side is where the physician is actually creating their note. So it isn't a typical workflow for a surgeon, so it is familiar to them and easy to pick up. One thing you'll notice, we have these red triangles, green checks, and yellow triangles, and those are the prompts or the visual cues for the physician to know, that they are actually done with their documentation. So in the top left corner here, I'll go ahead and select one of my custom reports. So I'll go ahead and choose my lap chole acute. So that's going to go ahead and apply my standard report for this procedure selected. So at this point, I'm going to be able to document or specify diagnoses and document the things that changed for this case. So first thing you'll notice here is under the preoperative diagnosis, we have a yellow triangle for gallstones, meaning it's unspecified. So we'll go ahead and select that yellow triangle and specify this diagnosis. So we'll say it's got gallstones, calculus gallbladder with obstruction. So post-operative diagnosis is typically the same as our pre-op, so we'll go ahead and pull that in. One thing you'll notice here is we do have a location question, and in this question, it allows the physician to use the diagram to actually diagram the location of those gallstones. So next, our procedure, it's already filled out, laparoscopic cholecystectomy. There's no additional questions, so we have a green check. Dr. Walker's our assistant. We have general anesthesia. Our blood loss and findings have red triangles, so we'll go ahead and fill those out. We'll say there was less than 5 mils of blood loss. And then our findings, we can say there was adhesions on the lateral wall of the gallbladder, inflammation of the gallbladder, et cetera. So one thing to note in these fields is it is going to start remembering things that the physician has previously documented, learning that behavior of the physician and using that technology to prompt the physician with things that they're commonly using. They can also use Dragon to dictate into any of these fields. So our specimen removed was our gallbladder. There was no complications noted. And then our indications and findings are the last two sections here. So Jane Doe is a 46-year-old female, had signs and symptoms of cholecystitis. Again, the physician can go in here and they can save these. They can also supplement this with the keyboard or Dragon. So the technique, this is the portion of the note that actually describes how I did the procedure. Again, this can be customized per physician and they can have multiple different drop downs here. So at this point, we'll go ahead and add a few images that we took intraoperatively to our note, and then we'll go ahead and e-sign this note. So once we e-sign the note, it's going to go back into our electronic medical record. It'll be available for any primary care or referring physicians, and also a copy of this report and the charge report can be sent back to my office immediately. So this is the final product that we generate. It's a PDF. It has the entire operative note plus the images, and then also we generate the suggested charge report. So within the suggested charge report, based on what the physician documented, we're going to populate the CPT and the ICD-10 codes. And again, this can be sent back to your office or your coder immediately after the case before the physician even leaves the OR. So what I want to do is jump back in here to another report and walk through a few different features or a few different things that kind of make Vincari different than your typical note generator within the EMR. So I'm going to jump over to the procedure performed. So one example I like to show is the excisional debridement. So the excisional debridement is a procedure that is heavily audited. Physicians typically, are leaving a lot of information out when they're typically documenting an excisional debridement. So one thing that Vincari does is it prompts the physicians, and it's kind of an anonymous query at this point. So that, they're prompting for the side, the location, the depth, the total square area, the tissue type removed, the instrumentation utilized, and the wound sizes. So from an HIM standpoint and from a downstream standpoint, this is, any of these yellow triangles are things that a physician could be queried on at a later date. So a lot of our physician users like this in the fact that they know the answers, they just don't know the questions that are being asked. So they do have an easy way to go in here and document all the portions of this excisional debridement that are pertinent to this case, and they know they're done with the note at this point. One other thing I wanted to pull up was something that Dr. Newman noted earlier regarding that thrombectomy or thromboendarterectomy. So this is a procedure that he himself actually discharged the patient when they had this procedure done. The patient was brought in as an outpatient. During the middle of the procedure, they did something that was different than what was scheduled, and that turned it into an inpatient-only procedure. So you'll notice here at the top of the report, we put this this orange banner to notify the physician that, hey, you are, you need to make sure this patient doesn't need to leave today, or the hospital will not get reimbursed for this procedure. So, Dr. Newman, Dr. Dullum, do y'all have anything else you'd like me to point out here? I can also show the mobile app at this point if we'd like to do that as well.
Well, yeah, I'll just comment that one of the most dreadful things that is ever told to me when we're learning other software tools is how we can build our own templates. And so one of the things we've done at Vincari is we've used crowdsourcing to create a library of notes. And Ryan went through a minute ago showing how you can keep multiple versions. And the reality is that we do have multiple versions of how we do things. We do have variable boxes that he's shown you, and now he's showing you the library. So for this procedure, there's many versions of how that might be done. And so in this manner, you can actually have a procedure that you're doing, and maybe you don't have a template, but there's likely one inside of Vincari that you can render and then change it for your own usage, and then name it, the Newman procedure, the Dullum procedure, put your initials on it. So this is a way that you can obviate the problems associated with creating de novo templates. So, Dr. Dullum?
Yeah, the other aspect to that too is because, like I was saying, we generated and kind of built these and our own, and then got the EMR to do them. That was nothing like what you have. You have an incredible, and with the AI. So the other aspect of that is, since as surgeons we tend to do a limited number. We don't do 70,000 different types of procedures. So as part of the training and the setup, once you use the software, is that on site the guys will be there and walk you through your reports and your usual ones. So the other side of that is you could dump in some of your regular operative notes and use those and change them, and it will learn specifically what you do. So you can also start with yours and use the extra added parts that you have here. And so immediately from the get-go, you're ready to go with all of your operative reports.
I think another common question we get is how long does it take to train physicians on this? And, I think we're very proud that as a company we've made the training of physicians a much easier output. And the reality is that surgeons by and large are fairly intelligent people, but not all of them have a high IQ when it comes to technology. And so, we have built this tool to make it easy to use, and most physicians under 50 or 55 years old need very little help navigating this tool. So I'm going to turn it back over to Ryan. I think he's showing you a lot about the mobile app that we use. All of us carry cell phones, and so in that manner we actually have a way to use the mobile devices to help us. So Ryan?
Yeah, absolutely. Going back to that point, this is all, this is available on any mobile app or any mobile device. So Android or Apple devices, you can access this through the App Store. It's a free download as long as you have access to Vincari. So you can see here we've got the report that we just created for Jane Doe. You can actually preview that report here in Vincari on the mobile app. You can see the full note. You can also see the charge capture report that we've generated. We can also see any other notes or anything that's been created under this patient within Vincari. So you can see any reports here. We can see any images that were captured. So those were those two intraoperative. One was intraoperative, one was a fluoroscopy image, et cetera. So again, we're just trying to make this very easy for the physician. putting it, literally in their hands on their cell phone or an iPad to be able to document their post-operative notes efficiently.
So, and I'll comment that I've routinely used this device literally on a daily basis to capture other information that I believe would be important to travel on the document. So, for example, cancer staging information that I'm asked about later, very often I might include a preoperative CT image or the staging forms and things that I haven't traditionally thought about including on the op note. The reason is that this operative note is a legal document, and it's meant to convey what happened at the operating room, but the reality is that it's able to do so many other things. And I do think that when we store images inside the giant PACS vault, very often they're lost in space. And so I actually believe, and this is my personal belief, my bias, that images that are captured at a operation or a procedure, a heart cath, a GI procedure, I think that those images should actually travel with the actual procedure that was done. So.
Yeah, and Lucian, the other thing I want to add to that, as one of the medical directors for Nuance, we spend a lot of time with physician education and quality, and one of the issues that we get with surgeons is you do your procedure and you send your specimen off the path, but you don't have your final. Patient ends up being discharged before the final pathology is back. And if we don't update the pathology on that, and it can be done after the procedure. A lot of surgeons don't want to do that because we were all trained you can't change the medical record. Well, here you got as a mobile app, you do it as an addendum once you have the final pathology, and it has a huge impact on the patient's diagnosis and also reimbursement. So, if initially you don't know it's a malignancy and then it does come back, this is very easy to add it. Otherwise, you will get, hopefully you'll get a query to clarify that and make it accurate.
Right. And
it take 2 seconds to do it.
Yeah, and I mean, a common thing that's done every day in every hospital is removal of skin lesions. And, very often we do know the path, but many times you don't. And the coding professionals behind you will, in every instance, wait on the path report if pathology's been sent. And so it definitely changes the actual CPT code. That doesn't mean that you can't go back and change. If I've committed to a benign diagnosis and it becomes malignant, the coders have been doing that throughout history with our written documentation and our dictations anyway. And so in this manner, it can easily be changed as well, and completely legally.
And because actually some sites, the coders will not do it without the physician actually documenting it. And the physician won't document it because they said, well, that it's not legal to change your operative note. You're not changing your operative note. You are accurately documenting the addendum of the pathology. And that's actually a common problem I see.
Right. And Ryan, if you can, I don't know if you can scroll down and show them the date time stamp. I mean, one of the questions we get from HM professionals is about reopening the document. And so every time this document is opened, you'll see a different date time stamp. And the reality is that, those are used to help know what happened. This is not like you're secretly changing a medical document. This is, you can see each different version. Each one of those versions we can render and see what it looked like before and after this document was created. So in case anybody's worried that this is changing documentation, it's not. It's recorded and date timestamp. Next, Ryan, are you done with your demo?
I was going to say, Dr. Newman, Dr. Dolman, I thank y'all for weighing in on that. I think I've shown everything that I've got. So I'll turn it back over to Karen for you to close. Great.
Okay, great. Thank you. As we're transitioning to share our final thoughts here, Dr. Newman, if you wouldn't mind weighing in, I know in the past the process for creating the brief post-op note and then having to come back later and dictate or complete the final operative report had been time-consuming and difficult. And if you wouldn't mind just telling us How long does it take you to complete your note now relative to what you used to have to do?
So what Karen's referring to is the IPPN, immediate post-procedure note, and the problem with the IPPN is it never said anything. We literally just scribbled cabbage or LC or colon resection. It was basically meant to convey information back to the recovery room and to the floor nurses, because historically the dictated note that had been looked at was not available immediately. And so the difference with this tool is I actually use Vincari as a timeout procedure, and each and every patient that I'm going to operate on, I pull this up on my PC or my device, and I actually look at what's wrong with the patient, what are their comorbidities, what is my planned operation. All the information that I can actually capture on that patient is available before I ever scrub my hands and put my gloves on. When I take my gloves off and walk over to the PC, I consider it to be a best practice to have the PC and the screen in the operating room, although many surgeons choose to go down to the hall to a private or quiet room. The reason they did that, historically was for quiet, and they had to think, but very often they took the medical record with them. I think that doing this actually in the physical OR is a bonus, and of course everybody can choose what they like about this. But bottom line, answer to Karen's question is literally 60 to 90 seconds, because at the end of a procedure, I'm specifically adding what is different about the case I just did. What are the specific findings, and did anything change? Ryan said, you can add the post-op diagnosis as it being the same. Sometimes it does change. I mean, I recently did a case that I had a lap chole that I was doing, and the lady had metastatic ovarian cancer. So obviously a dramatic change, and I took photographs so that my oncologist can see exactly what I saw with studying on the diaphragm. So bottom line is this is a very fast tool. I think our biggest fans are surgeons. When surgeons are shown this, we have comments from them saying this is has made my life better. It's made my life easier. It's not an egregious process. And so that's the reason we're so excited about having this to offer other surgeons.
Certainly something to help address burnout that we've seen in the industry today too. Dr. Dellum?
I'm sorry. Yeah, and I think that's right. So you get more accuracy for all the reasons we discussed. It's critical because we don't talk to each other like we used to. So now, it's there in the chart. It's documented. All of the healthcare providers can see it. It's faster for the surgeon. It's the other thing is that the information goes out immediately, or the charge capture goes out, but also this information goes to the primary care physician, which, as we know, as surgeons is very important because the families are going to be calling the primary care to ask them about problems. And so this is better satisfaction for your referring physicians, as well as improving, your quality of life and tracking your outcomes, and would allow for surgeons to do more cases or spend more time getting out of the operating room and doing other aspects of healthcare that they need, and also will increase turnover time in the operating room. So it's a benefit everywhere. And then you're not at home taking time away from your family trying to do an op note that was done in a few seconds down in the operating room at the point of care. It's the perfect solution, very elegant, perfect solution to what we need.
Sure, and an important step towards better communication and coordination of care, for sure. Dr. Newman, would you like to take us through the final thoughts?
Well, obviously we've belabored the point today over what is AI, how does it work. I think what you see here is our efforts at making documentation better and easier for surgeons. And as you use this tool, it gets smarter. When you turn this tool on, you're basically turning it on as an infant, and it becomes a teenager and then an adult. And by that, what I mean, it's learning your behavior, and you'll see the benefit as you use it. More of your information will be there. The documentation will be faster. And, as a company, we couldn't exist unless we were making our end users satisfied with what we're doing. And so, I've always told the folks in our organization the last 7 words of a dying organization is we've always done it that way before. And so we're constantly looking at ways to change and improve the way that documentation is delivered. And we're very proud to have a partnership with Nuance to expose everyone in this country and all surgeons to this type of documentation tool.
Yeah, and yeah, Karen, on this slide, the other area too, as we said, the satisfaction and efficiency, but you know, it prevents the physician burnout. And Dr. Newman, you always talk elegantly about how we are documentation minimalists as surgeons, is because you're focusing on the operation. But now we really, you know, the quality of our documentation is as important as the quality of our care. So this puts everything together and makes it much better.
Agreed.
Okay, great. With that, I think we'll wrap. I'd like to thank everyone for spending their time with us today and hearing about this important message that we have around better clinical documentation. I'd also like to thank our speakers. And if you'd like to talk with us or learn more information or even schedule a demo for your surgical staff and to see how our solutions can help improve your efficiency, please contact us here at the information provided. And with that, thanks again for your time, and have a good rest of your day.